Good afternoon. Welcome to the NYMAC Transition webinar series. We are here today to talk to you about transitions. Thank you so much for joining. NYMAC is the New York Mid-Atlantic Consortium for Genetic and Newborn Screening Services that is funded by HRSA, the Health Resources and Services Administration. We're so pleased to have all of you attending today. We've got three great presenters who are very well versed in transitions. Our first presenter will be Dr. Jennifer Lecomte, who will be talking about transition from pediatric to adult medicine. Jennifer is the medical director in transitions at the Christiana Healthcare System. Jennifer, thank you so much for joining us, and please begin your presentation.
Thanks. Good afternoon, everyone. I'm really excited to be here to talk about the internist perspective. And I'm not able to move to the next slide. So let's just go to the next slide. So I'm one of the MedPeds providers, internal medicine and pediatric providers at Christiana Care Health System, and I'm the medical director of our transition care practice. So if we could just go to the next slide.
Sorry, I don't know what's up. Give me just a moment.
Sure. Should I go back? Sorry, everyone.
Can you see it now?
I can.
Okay.
Let's see if I can, and I can go. So I just want to briefly remind everyone what we're talking about, the transition process, and give you some perspective about the barriers and how we can collaborate together about promoting our patients' autonomy as well as being successful in getting our young folks with conditions that originate in childhood to the adult providers and share with you some literature and really why we're here, because children with chronic conditions are living into adulthood. But some of the realities of transition is that there is a checkout time for their access to the pediatric side of their healthcare experience. The reality in my own system here in Delaware, and you'll get to hear a little bit more about that from Corey Norrie later, is that at the Children's Hospital, AI DuPont Hospital for Children, our patients can't be seen there after 21. So we have to start to plan for their transition to the adult side. And the idea of healthcare transitions has been around for a while, but fortunately our adolescent folks defined it for us that the transition is planned, it's purposeful, and it's getting our young people with chronic conditions from the child-centered health system to the adult-centered health system. And that's, we really went from that model, and to understand that we know that if we don't plan and we just transfer our patients instead of using the transition process, that we'll see poor outcomes. Now this data isn't specific to my practice in the transition care practice, but in the transitions literature, that if we don't have a process, we will see worse outcomes in patients with type 1 diabetes. Their glycemic control worsens, that we'll see graft failure for our transplant recipients, that we'll see increased morbidity and mortality in our patients with congenital heart disease, and unfortunately we'll see increased rates of hospitalization for our patients with CF. And this is true across a multitude of our disease processes. So one of the ways that our transition care practice used to try to design our practice is understanding the process. We used a consensus statement that really showed the initial collaboration between the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians. So we got our pediatricians, our family docs, and our internists together to generate this consensus statement on how do we get our patients across the border, and we use that to kind of design our practice. The one unfortunate part is that it was published in pediatrics, and one opportunity that we still have moving forward is to make sure that we can publish these guidelines and these processes across different formats that all of our providers can see. So, you know, our internists are reading the Annals of Internal Medicine. We need to get more of these processes published in those venues, or in things like using our NYMAC and GOT Transition, Society of General Internal Medicine, really to get us to the next level. So we used the consensus statement to find the goal of healthcare transition, and this was, I think, really this is the goal for all of our patients. Everyone wants to maximize their lifelong functioning and potential, and they want to receive high-quality care that's developmentally appropriate, and then it's uninterrupted as individuals move across settings. Specifically, obviously, we're focusing on moving across the pediatric setting to the adult setting for my practice, the transition care practice, but really I think we all want that. And when we speak about developmentally appropriate care, especially when we're talking about patients with intellectual and developmental disabilities, that's important. But it also speaks to our healthcare literacy and making sure that all of our patients can really understand how they access healthcare. So the consensus statement really identified 6 critical first steps in transitioning patients from one setting to another. And the rate limiting step is often how do you identify a primary care provider. And really we see our patients are really struggling with identifying an adult primary care provider who understands their complex conditions, especially when they originate in childhood. But there's all these additional steps that need to happen, and part of this webinar is to help educate other providers, educate our family members, educate our patients about the transition skills that they need, and really have a process. So I'll go through some of these throughout this presentation. So there are a lot of transition issues to consider when we're talking about childhood onset conditions and patients with special healthcare needs, intellectual, physical, and developmental disabilities. And Corey's going to hit a lot on these topics in her talk in just a couple of minutes. And you'll have access to these slides in the future, and there are links to the NYMAC webinars. NYMAC supported some YouTube videos that will allow patients, providers to access these resources anytime they want. So we use the consensus statement to start to develop a philosophy for our transition care practice, and specifically we were focusing on patients who had special health care needs, who were leaving AI DuPont and utilizing the transition of care consult service that Corey will tell you about, and really having a process for transitioning them. One of the things that are unique to our transition care practice is that we are really focused on being a medical home and a primary care for patients with a variety of special health care needs. So while there are some, and you'll hear from Peter soon about disease-specific programs, we were really focusing on becoming a primary care practice for really a variety of healthcare conditions. So that includes those with intellectual disabilities like autism, and as well as genetic syndromes like cystic fibrosis, and then others like spina bifida, Duchenne muscular dystrophy. We really have a significant variety. And then also those with physical disabilities like cerebral palsy. And we really wanted to focus on the tenets of patient-centered medical home, the chronic disease model, and the shared management model, which I'll explain a little bit more. And then really develop a network of providers so that we can really make sure that our patients have choice in who they see in the future. So the shared management model really tries to promote greater autonomy among our young people, even those with pretty impaired intellectual abilities, and really change the responsibility from the parents to the patients and have them become more autonomous in their care. We know that if we approach a patient and allow them to be better self-managers, we will engage them in protecting and promoting their health and really adhering to, again, going back to the guidelines, the preventative health measures that often our patients with special health care needs, once they get into adulthood, are falling behind in those measures. When they're seeing their pediatrician on a regular basis, they really do focus a lot on preventative health. Unfortunately, what we find with this patient population is that as they cross the line from pediatric to adult care, they're really not focusing on healthcare prevention. So they're not necessarily getting their mammograms and accessing women's health. They're not getting their immunizations as they once did as a child. And so we're hopeful that we'll be able to engage them more in protecting and promoting their health, understanding their current signs and symptoms of their illness, how it impacts their life, their jobs, and really get them to adhere to their treatment regimens better. So initially, when we started our transition care practice, we really wanted to look at compliance with the adult immunizations, that we got them access to their GYN care. We're still working on developing our subspecialist groups and making sure that we decrease emergency room use so that if we did not have any interruptions in their care, that we'll see better outcomes. We also wanted to make sure that we were educating other healthcare providers and other support staff about how to work with patients with special healthcare needs, so that, again, when our trainees leave our system, that they're more likely to accept patients with special healthcare needs and childhood onset conditions into their practices. We know that they're going to encounter these patients on the inpatient side when they become subspecialists. We know that because we can celebrate the successes that our patients are living into adulthood. In the past, patients with CF didn't live past the age 7 in 1970, and now we're seeing patients survive into their 40s. And while pulmonologists used to not have to encounter them, these patients, now we're celebrating those successes. So we really want to educate all of our healthcare providers, and we're working with all of our community resources in order to develop those alliances so that we can better support these patients. And why do we do that? We know that at least in some of our surveys that if we educate these healthcare providers, that they are going to accept these patients into their practice and feel comfortable about it. The unfortunate part is, even though that we know that if they're exposed, they are more likely to accept these patients, what our survey shows is that they're actually not getting exposed, and so that's what part of the transition care practice is allowing. We have a transition elective that our residents can participate in. Right now it's our internal medicine and pediatric residents, but hopefully in the future we'll be including our internists, our categorical internists, so that they can start to get exposed to this patient population. Certainly we're educating them in some of our noon conferences and our morning reports, but we want to do that more frequently. So the other really big key with transition, especially with educating adult providers, is really that developmentally appropriate approach to our patients. Dealing with patients who have chronic conditions, who are in their adolescent stage of development, can be really challenging for a lot of different reasons. So, and our internists aren't as well versed in understanding the adolescent brain. And so what we're hoping is that if we expose our trainees, that we'll start to really engage our adolescents more appropriately. And so I have a couple of things of how we do that. Fortunately, in my practice, I'm able to see patients for a longer period of time. So I have 1-hour appointments for new visits, and I know that that can be challenging in our current healthcare system of allowing longer time to see patients who not only have special healthcare needs but are in their adolescent stage of development. And one of the resources that you've already learned about in our last webinar is the Gut Transition website, and how do you engage your leadership to really embrace allowing more time for this. And I think that as our healthcare systems evolve to more population health, we'll start to embrace that in a better way, and really allowing our young people to participate in their healthcare system. And while we know that they can be impulsive in their decision making, certainly if we engage them in being part of that decision making, they'll be more adherent to some of their care. So we have lots of opportunities, and I think that Corey is going to be talking about some of the opportunities of engaging in the community. But really, one way that we've been successful is having a portable medical record and communicating with each other and knowing each other, because I know the pediatricians who are referring them, and they can feel comfortable that they know the adult providers. Unfortunately, we don't have a lot of settings that allow pediatricians, internists, and family docs to communicate, and this is one of the great opportunities that we can do that. So oftentimes, this is the fear of our internists, that we're going to get these giant boxes of records without really having a good communication. And sometimes folks think that having a flash drive with all this information is helpful, but really we need to just have a clear, concise document, and that is what my relationship with the Transition of Care Consult Service at AI DuPont provides for me. It allows me to look at baseline exams, imaging, and really a concise way. And it's a really good opportunity for our pediatricians to engage with their patients, to use it as a tool so that we really are assessing our patients' understanding of their medical history, a way to document what the care plan is moving forward. It's a way for our primary care doctors to review new guidelines and recommendations. So having that transition document is really going to be an important way to move forward. So where do you go if you're an internist or a family doc and you don't know where to go for these, for guidance and caring for young people with with childhood onset conditions into adulthood? There's lots of places where you can find information, and at the end of this slide set you'll see an access to more information. But again, unfortunately, a lot of times you're going to have to go back to the pediatric literature, but that as long as you know that, the disease-specific support groups and the websites like NYMAC's website are very helpful. Going back to the pediatricians and the pediatric specialists and actually just having a conversation with them is going to be invaluable. The Society of General Internal Medicine now has a task force that is creating an opportunity for how we educate adult providers in caring for adults with complex conditions. And we're hopeful that we can start to build a bigger community so that we're so that our adult providers have a format to go back to, and if they have questions, they can really have a better way to interact with their patients with childhood onset conditions. And certainly the Gut Transition website is really helpful. So I'm happy to take questions at this time, I don't see any questions currently, but if you have any questions, you can go ahead and use your question and answer.
Great. Thank you so much, Dr. LeCompte. That was very helpful. For all of the attendees, on your webinar dashboard, you should see a place to enter questions. I will be providing those questions to Dr. LeCompte, so please take a moment if you have any questions and type them into that section. If we don't get to any of your questions today, please know that we will follow up with you on being able to answer those. So we do have one question. The question is, who is the task force with?
So the Society for General Internal Medicine is a medical group for internists and the task force was created, it's a long name, it's Caring for Adults with Complex Conditions Originating in Childhood. So internists can be a part of that group. Interestingly, just recently, understanding that we really have to work in teams more, so Corey actually presents at our national meeting, So we do accept members who are not internists. The Pediatric Academic Society also has a special interest group on healthcare transition. So if you're on the pediatric side, they also have a complex care special interest group, and that's another way to get information on how to care for these patients.
Great, thank you. Another question, how do you modify your approach for patients who will never be able to self-manage their care?
So that's a great question. I still think it's really important, and it's one of the first things that I do when I'm teaching a resident in approaching this patient population. Our internists also have to be able to interact with families and caregivers. So I still address the patient first when I go into a room, and I think that's still really important, even if our patient is not going to be an independent self-manager. So we still engage the patient and speak directly to the patient, so that's helpful. But yes, you're going to have to also work with families and with the often home health aides and nurses at home, because it is a team approach.
Great, thank you. And we have a question about the process for how do you get records from the 9 different providers that the child sees, so somebody who is trying to get records from 9 different people, and any tips for how to do that?
So, well, one of the ways that, and I guess Corey might actually answer this question, they've actually created a records request that can help facilitate that for some of our disease-specific processes. So we know that if we have a patient with cerebral palsy, that we need to actually get their last imaging studies, their last ortho report, and we can do it all in one document. Now that's helpful in a system like mine where you have one tertiary care center. It is more complicated when you have multiple providers that don't work for the same system. But again, generating those requests and pre-generating them and having them done before you actually see the patient can be really helpful.
Great, thank you. There was one question about the slide availability. The slides will be emailed out to everybody who has participated in today's webinar. As well, there are some questions, and I apologize that we're not going to have time to get to all of your questions today on the webinar, but we will work with the speaker to get those questions answered and sent out to everyone who participated. So thank you very much for taking time to put those in. Please continue to do so and know that we will address them. The next speaker I'd like to introduce you to is Dr. Peter Gillette. Dr. Gillette is an internal medicine and hematology specialist at Downstate Medical Center, and he will be talking to us today about the adult side of sickle cell disease. Welcome, Dr. Gillette.
Thank you very much. I see you're going my talk backwards. I guess we just finished the talk. That's nice. I'll be talking about transition in sickle cell disease. Where's my click on the screen? There we go. Objectives for this talk are to understand the strengths and weaknesses of transitioning from a pediatric clinic to an adult clinic, but just in our hospital setting, because we've had some problems which might be instructive. My goal is to get everybody stimulated to think and write and generate action to work with the Affordable Care Act and work with insurers to get funding for transition. Another goal is to recognize the provider's need to ally with institutional leadership. This is from a university hospital and a city hospital that I speak here. We have to develop the protocols, and we got to create the concept, which is not well grasped, about a PEDS med transition navigator, or whatever you want to call it. No disclosures with respect to these items. For many years, the median lifespan of patients with sickle cell was assumed to be about 5 to 10. Actually, in rural Africa, the median lifespan of a sickle patient is about 3 to 5. In this country, it's managed mostly by pediatricians, but now lifespan of sickle cell disease is rising. It's in the 40s, on its way to 50, and we have patients in their 80s. So the need for transition of adolescents and young adults became increasingly evident with us about 20 years ago. Individuals are living longer. We discovered milder or more modified types of sickle cell, and for hematologists among you, that means increased hemoglobin F or alpha thal. Young adults were moving on. They're getting a school, jobs, and family obligations. But improved quality care was why people lived longer. So at Kings County here in Brooklyn, the pediatric sickle cell clinic began in the 1950s, our adult clinic in the 1970s, but there was no transition until recently. The PEDS program was so good that patients stayed into their mid-20s or until they became pregnant, or as the joke was, until they got too long for the 5'6" beds in the hospital. A maternal and child health initiative offered an RFP, which we responded to study the issue of transition. Scott Miller's head of PEDS here, and he and I got this grant for 3 years. We had a full-time social worker. Her work scope is essentially 100% transitioning, and she attended both clinics and counseled in both areas. She identified the patients for transition. She sat with each patient. She set up meetings with patients and one or both parents, often outside the clinic time, and patient travel to the meetings was grant funded. She set up the transition counseling group in peds and adults, and she walked the patients and the parents to the adult clinic to show them the program, introduce the staff, and to demonstrate the continuity. She set up the dates at the patient's and parents' convenience. She facilitated the records transfer and interaction between the peds and adult physicians. Then she walked the patients over and continued to follow the patients later on, if necessary, even by phone. Results were not highly evaluated, but after we transitioned about 130 patients, the general impression was that it was reasonably successful. Over 90% of the individuals stayed in the adult clinic. We had, however, to get increased staff in the adult clinic, and we had to go for external funding. Our hospital was unable to support it. So at the end of the 3 years, a model was put in place for less intense transitioning, and the program was terminated. But you anticipate what the next slide is going to show you. We have no transition dedicated social worker. We have nobody named a case management specialist or a navigator for transition. The work scope of transitioning was added to the existing social worker, who is 50-50 peds adults, but she's now responsible for all the counseling and concrete services for everybody in peds and adults, outpatient, inpatient, plus transitioning. So obviously it was unrealistic, and transition faded. It's a lower priority. So in sum, since then, peds adult transitioning has lost its richness and effectiveness and has reverted to mostly unsupervised transfers, delays, and losses of patients. Some adolescents without strong family ties do try it on their own and make out, and some don't do very well. Our busy general hospital, with its overloaded adult clinics, discourages independent young adults. Some delay coming when they're sick, and some try to go elsewhere. So why isn't it working very well? Well, we have no dedicated person. We have an increased number of patients where New York City is reducing the number of docs, nurses, and PAs citywide due to budget constraints. There was one wisecrack the other day, what's your waiting time in clinic? And if it's too long, why don't you do better? And so we said, well, we refer you to the mayor, and he'll take care of it with more staff lines. So transition work scope has been added on top of everything else, and the social worker has approximately 300 active patients where the standard workload is perhaps 1/10 of that. So transition works sometimes, but the patients who need the guidance most appear to suffer the most. So basically we return to system overload. Now here are some broader issues One is parental guilt, which we label it. Adolescents with sickle cell disease have a genetic disease which some parents often feel deeply responsible for throughout their life. That's different than if you catch an infectious disease and now you have a chronic illness. This often leads to parental guilt, overprotection, and underdevelopment of adolescent and young adult ego, initiative, and independence. It's common sense. It often leads to excessive adolescent testing behavior, willfulness, non-adherence, and so on, and it can lead to opioid problems. Another issue specific for sickle cell is stigmatization. Sickle cell painful events are often unexpected. They can be frightening, and many adolescents appear to try to hide it as a weakness in our power-based culture. Many apparently do not share their pain with their friends or even with others who have sickle cell disease. This works against them becoming interactive adults, such as wanting to take charge of their transition. Another broader issue is cognitive dysfunction. This is specific to sickle cell. It's been known for many years that about 40% of 18-year-olds already have silent CNS damage, even without major manifest signs of stroke. This is established by neurocognitive testing, language, square peg in the round hole, that sort of thing. But the newer data is even worse. Just recently, the National Stroke Study has shown that 15% of 15-month-old patients already have silent sickle cell brain damage. So behavioral difficulties with adolescents and young adults can have primarily organic rather than psychological or social or cultural roots. In sum, recognizing cognitive dysfunction and treating with kindness and patience are major parts of sickle cell care, and transition is, of course, one of those aspects. But the effects of unsuccessful transition can take years to overcome and can leave patients with increasing organ damage, especially during these early years when they're not getting adequate care. So what are our strengths in this system? We have established clinics. They are near each other and walkable back and forth. There's ease of communication. We have good record exchange. There's good communication. We have the same hospitals for inpatient care, both downstate and Kings County across the street from each other. And then in general, the hospital staff are experienced with sickle cell disease. This is a focus for sickle cell care for the city of Brooklyn. And our catchment in Brooklyn is probably about 1 million people. So what are our weaknesses here? No dedicated staff member, overloaded staff and appointments. We can't link family very well into the adult clinic. We have no support groups, either in peds or in adults. And we have no young adult focused caregivers in the adult program. In other words, we should have people who are focused on post-pediatric early adult care. We don't have such. So what are the issues? There's a low-level appreciation of both the perceived and the real difficulties of transitioning. It's a lot more than scheduling, said one fellow. How do we change administrator expectations? How do we change staff behaviors and expectations? How do we exchange patient expectations? How do we enrich the system? So what are some approaches? Well, I picked 5. Institutions need funded transition positions, period. Clearly, one intent of the ACA is to enhance care to 18 to 26-year-olds. That's exactly the transition focus. It's right on target. Number 2, insurers have to pay for transition counseling and for facilitation. As Jennifer said, she spends an hour with a new patient. We probably spend 2. So this may be the first mission for NYMAC and HRSA, is to strengthen these rationale and get us involved with, ultimately, action on legislation. We have to educate our institutional leadership to understand the need for transition. And we have to do our own needs assessment and evaluation studies to convince the administration. Number 3, institutional leadership needs to prioritize transitioning. So maybe NYMAC and HRSA can work on national guidelines for transitioning. Job descriptions for different types of transition members in different systems. Cross-departmental work, peds and medicine doing studies together. We have to be continually on top of working with department chairs, human resources, and finance. We got to develop the protocols. And we got to make allies of our chairs and directors of nursing and social work so they understand it. And number 4, we have to write the job descriptions, the protocols, and we have to do the alliance with the leadership. So we're going to create at Kings County the concept of a PEDS-Med Transition Navigator, and we'll see how it goes. It's the same thing that you would put into the job description, but I think one of the strong points is this has got to be a people person. So the individual in this job has got to have the right skills. Number 5, we create this person now as a change agent. And those of you who read psychology or social psychology literature, you understand the concept of a change agent. So you know what you want to do, but the trick is how do you get it done? And there's a lot of work on how to do that. But most importantly, you got to get the institutional commitment and an individual with the right kind of skills. So those are the 5 things. I had a slide in here about what's a change agent, but you can look that one up. So here are the 5 things. We got to have funded positions. We got to have insurance pay. Leadership has got to prioritize it. We have to set up the job descriptions, and this is what we're going to do here at Kings County. We'll see if it works for us. So what's the bottom line? Bottom line, at least in my view, and this is only one observer's comments, and this is only one subspecialty in a complex disease with many complications in every organ system, right? But basically, it's up to us to demonstrate the need, the rationale, and the significance of transitioning to our leadership. And then once we get them thinking about this, then we help them design the system and then hire the right people. So those are my thoughts. Thanks. Any question, please ship them in on your screen.
Thank you so much, Dr. Gillette. That was wonderful. We do have a few minutes for questions. Again, please do enter those into the question box on your screen.
While we're waiting, I could answer one that came from last time. And this was addressed by Kathy Hassel last time and by Jennifer this time. Both Kathy and Jennifer recommended starting transition about age 12 or 14, not waiting until you're 18 or 20 or 22. And what they're doing is generating the individual's autonomy over a period of time. And that's the reason for starting early. Yes.
Great,
will the slides
thank you.
be available? Yeah, my slides will be available.
Yes, yep, all of the slides will be sent out afterwards. Great. Well, thank you. If there's no other questions, then we will go ahead and move on to the next presenter. Our next presenter today is Corey Norrie. Corey is a patient transition social work coordinator at AI DuPont Hospital for Children, and she will be talking today about a dedicated transition center. Thank you very much, Corey. Please begin.
Hello, everyone. Thanks for letting me participate today. I am Dr. Gillette's answer. It actually exists, and so I'm so excited to tell you about how we've done it here at Nemours AI DuPont Hospital for Children, and hopefully share a lot of information that could either be replicated elsewhere, or at least we've done a little bit of legwork for you potentially in going back to your system, whether you're a provider or a family or a patient yourself. So because I'm not a doctor, I don't ever do objectives. So I'm going to talk about the stuff I'm going to talk about. The definition of who we talk about typically when we talk about young adults with special health care needs are usually people between the ages of 14 and 30 years old. And we're talking about young adults who have some kind of complex medical issue more than that of their typical peer. And in the state of Delaware, which is where I am, it's about 20% of the children between 12 and 17 fall into that category. So Dr. Lecomte mentioned earlier that the goal of transition is it's a guided process rather than an administrative event. And so people oftentimes get confused between transition and transfer, and they're two very different things. The transition is a process, and the transfer is the actual one day you see this doctor, the next day you transfer to this different doctor. And the goal is that there are no surprises about the transfer when it has to happen because there's a transition process in place. So we actually use this same slide that Dr. Lecomte showed earlier because at the hospital system I work at Nemours, our age policy is that we stop taking care of young adults on their 21st birthday. And there's a few little caveats of exceptions here and there, but by and large it's 21. And that, in a lot of ways, has facilitated the development of a transition program. And I often get calls from all around the country with people saying, wow, you're so lucky that you have an age limit. How did you do that? And it's actually about the way that we are funded. We are created by Mr. DuPont's trust, and the court interpreted his trust to, his trust that money was left to take care of children, and they interpret it to be 21st birthdays when someone stops being a child. So it's interesting that a lot of people want there to be an age policy because at least then it means that something has to happen. So to give you a sense of what we've done here at the hospital, we are an actual division in the hospital under general pediatrics. We're the Division of Transition of Care. We're a consultation service. It's the entire department is my physician partner, Dr. Amy Renwick, who's a general pediatrician with a lot of expertise in special health care needs, and myself as a social work coordinator. We started the transition clinic itself back in January of 2010. And a question I often get asked that usually would come up later on is about how do we get this funded, how do we get this going through, and Dr. Gillette alluded to it earlier. We actually, before we had an actual program here and I was being paid to do this, we had a study done by our Title V program here in Delaware asking our graduates how their transition and transfer into the adult world went. And overwhelmingly, the feedback was not very positive. And so having that data to go back to the administrators and the team here to say, listen, we've taken care of these patients for 21 years and they're not having a good experience because we're not helping them enough, really I think was the driving force behind creating a formal transition program. So that would be a recommendation I would have for anybody who's interested in actually getting something established. So I'm going to talk about how our clinic is actually set up and what I talk about and what I focus on as the social work coordinator. We have 90-minute long appointments, which is a long time, and we actually use every single second of those 90 minutes. We follow up based on the patient's age and their readiness, and so if we have somebody we meet when they're 16, we may have a 90-minute long appointment and then not check back with them and see them in the formal clinic again for another 2 years, or sometimes it's 3 years, depending on where they are in their life. And everybody is so unique and individualized that really some people we see every 6 weeks because they're going to need a lot of assistance making the transfer sooner, and some people we don't see for a couple years, but I do a lot of things via email and via telephone in between clinic times, helping people and catching up and those sorts of things. We offer both an ambulatory and an inpatient service. And one of the questions that came from the last webinar that I wanted to address was about how to develop those relationships with the adult doctors. One of the things that we added in about 2 years ago now to our service is when we get a consult for somebody and we order or we schedule them for our transition clinic, we automatically generate through our electronic medical record a letter that goes out to their PCP that's listed in the chart. And on that, we ask a series of questions. One is about what age will you stop caring for this patient, because sometimes people have a pediatrician, sometimes they already have a family medicine doctor, sometimes they already have an internist. And so we ask them what age they'll stop taking care of the patient, if any age at all. We ask them if they are interested in acquiring more young adults with special health care needs for their patient practice. We also ask if they have any knowledge of community or adult programs, adult specialists or connections that they have because they've been the PCP for so many years. And then we also invite that PCP to our clinic appointment if they're interested, whether participating in person, via telephone, or via FaceTime or those kind of video chats. We've had several doctors who participated who it's really a nice way, a nice handoff for the primary care doctor to get involved in that and be part of the discussion, and also for the family and the patient to see that, wait a minute, we're really working collaboratively here amongst the systems, amongst the providers. So that's one way. And that's one way we've networked, and by finding PCPs who say, yes, I'm totally happy and capable of taking care of young adults with special health care needs. Send me more. We've been able to facilitate some of those transfers, and that's one way to do it. The actual transition service itself, the role of the pediatrician is reconciling medications, and we are on EPIC, which is an electronic health record, which is wonderful. And one of the things that we spend time doing in our reconciling medications is actually making sure that the route and the frequency and the dosage are all actually correct, because a lot of times the default is by mouth, and yet many of the young adults we work with don't take anything by mouth. And so we actually update the record to be completely reflective of who they are on that day we meet them, so that way going forward it's already established that everything's via G-tube or J-tube or GJ-tube. We also review the management of the chronic conditions. We talk about new medical issues, and we go through what each doctor they currently see. So every specialist they see, whether it's in Nemours or outside of Nemours, we talk about every single system and every single specialist. The doctor ahead of our appointment actually goes through and grabs the most pertinent, relevant information from the recent outpatient notes or inpatient notes from the different specialists. And so that way, as we're sitting there working with this individual patient, we can say, well, Dr. Smith said at the last appointment that you were supposed to increase that medicine by, twice a day. Have you done that? That's not what you said earlier. And so we can actually check things right there in the moment to make sure it's accurate, and we can update it so that way moving forward it's accurate for the new doctors. We talk about identifying potential adult providers. And one of the biggest differences, so we're here in Delaware, which is a tiny small state, but we're really in a kind of a 4-state area. And so our patients come from primarily Delaware, Pennsylvania, New Jersey, and Maryland. In the adult world, Medicaids don't cross state lines, and in many of our patient cases, that's what they end up having as their insurances. And so we have to be able to talk about, based on what kind of insurance you're going to have and where you live, here's the adult doctors we think are best suited for you in this one system. And we tend to rely more on larger academic centers, if it's possible, just because they tend to have more physicians available, more specialists, and who may have been exposed to more complex special health care needs. Clearly, that works if you're in an area where we are. If you're in a more rural area, you may not have that as a resource, and that's definitely a barrier that, sometimes we talk about someone might have to travel quite a distance to get to see that specialist, which is one of the reasons that Dr. LeCompte mentioned earlier. The primary care doctor is the absolute most important person in the adult world. It's having a solid primary care doctor and being able to develop a program like the one at Christiana that she talked about, where we know we can send our patients who are very complex to her, and she is more than competent and capable of taking care of them and doing wonderful things and making sure they have a great quality of life. So the PCP is absolutely essential in the adult world. We spend time providing anticipatory guidance and talking about how it's going to be different. And at the last webinar, there was a discussion about, the adult world isn't so scary, even though that's the perception in the community. But we spend time talking about that autonomy and that expectation that young adults are going to be more involved in their care, whether they use words to communicate or not, whether their parent has obtained legal guardianship or not. The expectation is that in the adult world, these young adult patients, no matter how complex their medical history is, are going to be more engaged and more active participants in it. And so we talk about sometimes the parents letting go of some of the rein or some of the control a little bit, and the young adult rising to the occasion, and some strategies and steps to help with that. We talk to the current providers and get a sense of what's going on. And then I think that one of the biggest benefits, and Dr. LeCompte alluded to it earlier, is that our pediatrician, our transition of care physician, puts together this medical summary that is a complete document of our entire 90-minute appointment, and that gets mailed to every single patient who sees us. So if you see us when you're 16, you're going to get a medical summary of you at 16 years old, and you come back at 18, we're going to update it from that last appointment we had with you and have all the new relevant past 2 years worth of information in it. So that way, at whatever age you actually transfer to a new doctor, whether you move out of state or you move away to college, you have a document that's accurate and up-to-date right there. The role of me as a social work coordinator is, the way I phrase it, is I talk about all the things that people do the 362 days a year that they're not seeing doctors. And so these are different domains that I talk about. And this is usually the area that most people come to me from around the country asking for kind of advice or guidance about. So I'm just going to go through a highlight of some of the aspects I talk about in transition. And these slides are all going to be available. So, and then afterwards, I'm always available if people have questions additionally. So we talk about long-term planning on where the young adult is going to live. And the continuum ranging from a lot of the young adults we work with, the parents' belief is that that child will live with them forever, which is a completely fine plan, except for the fact that sometimes parents pass away before their kids do. And so it becomes a bit of a challenge that way. And we talk about planning for that when that happens, so it's not such a crisis or chaotic moment. Instead, it's a planned discussion about who would step in and who would take care of things. It's also another reason we talk about estate planning, so that way people are supported when that happens. We also talk about the wait list for services, so if somebody wants to live in a group home or in some other kind of residential program, every state there are wait lists for those kinds of supports. And so if I'm working with somebody and they're almost 21 and the parent's goal is that their child moves into a group home, but they're not registered in their state agency yet, that's going to be a big barrier for them. And in Delaware, the wait list is at least 10 years, and I know around the country there's other places where it's 20 years. And so we talk about then what's the emergency list look like and how do you help people and connect in that way. Some states have an Office of Aging or Physical Disabilities, and getting them connected to those supports if they're eligible, also to their Office of Intellectual or Developmental Disabilities, which always has some variation of a name, kind of what you can see there on the screen. We talk about education and what people's long-term plans are for education. So we talk about, the federal mandate is that a transition plan is in place by the age of 14 if somebody has an IEP. And we talk about how that kind of marries the idea of the healthcare transition, right? You should have a plan in place, meaning that it's being discussed and people are working towards a common goal. We talk about whether someone's plans to go into continuing education, into college or post-secondary education, whether they're interested in a job, going to some sort of supported employment program, a day program, the whole variety and continuum based on their interests and their needs. We talk about if someone's going to college, the burden of proof of the disability is then on the student. You're entitled to a free, appropriate public education in the U.S. up until 12th grade or until you turn 21. And then if you go to college, you have to go prove your disability and what accommodations you need. And we talk about the onus and what that feels like for the young adult to have that burden kind of put on them then. And again, strategies to support them through that. Vocationally, again, the entire continuum of things, making sure people know about vocational rehabilitation. Every state has them. And then that there may be wait lists for certain services and supports as well. Additionally, we go into insurance and financial issues, so talking about if somebody has Medicaid already and do they qualify for the adult Medicaid, if they have Medicare. Many young adults I work with after they turn 18 will apply for SSI, Supplemental Security Income, and in this area when you get SSI you automatically qualify for the state Medicaid as well. We talk about the Affordable Care Act and the increase in the age to 26, and then we spend a lot of time talking about special needs, trust, and estate planning, because this is one of the areas that parents often have a lot of concerns about and they don't know who to talk to, that there are actually people who professionally their career is around special needs trust and special needs trust law and setting up appropriate estate plans that protect somebody's assets but also make sure that they're entitled to the supports that they're eligible for. So we spend time talking about special needs trusts, which allows somebody to stay eligible for SSI, meaning that they can have more than $2,000 only through the special needs trust and not have a count against their eligibility for government benefits. We talk about life insurance policies because if somebody has their adult disabled child listed as a beneficiary, that parent passes away, that young adult child gets a lump sum of money, then they may lose their SSI and their Medicaid because they have too much money now, especially if it's written that it goes into a regular trust, because a regular trust can't be retroactively turned into a special needs trust. And then also just now in December, the ABLE Act was passed, which will allow families to save up to $14,000 per year with a lifetime maximum of $100,000 and not have it count against government benefits. It's similar to a 529 college savings plan, and that's new. And every state this year is kind of focused on changing policies and rules around that, so that way they can uphold the ABLE Act, which is a really huge benefit for people. Again, Medicaid versus Medicare, depending on what someone's needs are and what insurance they have. Then we talk about legal stuff, and I know there's a future webinar where there's a phenomenal speaker about legal issues, so I'm just going to kind of highlight on it very quickly, and then know that there are additional webinars about this topic. But so on the 18th birthday, the idea that the young adult becomes legally an adult, the expectation is they're responsible for themselves, they can consent for treatment, they can sign legally binding documents and all those sorts of things. It's also HIPAA takes effect when someone turns 18, and so we spend time talking to families about what would it look like, what's going to happen when your child turns 18, what do you want for them? And so people kind of pursue a couple of different avenues. One would be legal guardianship, which would be going to the court system and having the person determined by the court system to be legally incapacitated to make decisions for themselves. Depending on what state you're in, there are sometimes limited guardianships or different types of guardianship. In Delaware, we have person, property, or both. And it's kind of you either get guardianship of person, meaning day-to-day decisions, guardianship of finances and property, or guardianship of both. We don't have a limited guardianship where only certain aspects other states have a guardianship that's only for healthcare decisions. And so it's really important to know your state laws around guardianships. It costs money and it requires, some states require an attorney. Many states do not require an attorney to file the paperwork. The parents typically can do that. But going back to guardianship, it's a big deal because it's legally removing somebody's rights. And once a guardianship is granted, you can't revoke it unless there's what you can prove a miraculous recovery. And so sometimes families come because they're looking out for the best interest of their child, no question, and they want to be protective. But it's important to recognize that once that guardian has passed away, depending on who you've listed, if you haven't listed surrogate next of kin guardians, then eventually, because that person's been determined to be legally incompetent to make decisions for themselves, then there's issues about becoming a ward of the state and who the decision maker is. So it's a big deal, and so we want people to understand that and to think about alternatives to guardianship if it's appropriate as well. One alternative would be a healthcare power of attorney, and again, you're going to have more information about it. But a healthcare power of attorney, the person has to have the ability to consent to authorize information being shared. And so it's just important to know that if they understand that, yes, they want their parent involved in decisions and help them make decisions, that can happen. And then it's also important to check with your state if there's a health surrogacy law, because if there's no document signed after someone turns 18 and there's a medical emergency or some situation happens where attendings feel that the person is not able to make a decision in the moment, then the health surrogacy law could kick in, and typically the first decision maker is a spouse followed by a parent. We also spend time talking about assistive technology resource centers and communication options, and it's important to know that every state has these available where you can borrow equipment and try things out. A lot of times people are assessed for functional communication when their child's very young, maybe early intervention age, and then determined at that age not to be ready for it, and then it's not brought up again. And so we spend a lot of time in our clinic saying there's probably some way for your child to communicate with you better, or especially as they're transitioning out of the school system where they've known people for 21 years, moving to an adult system where people don't know them. We want them to have as many functional skills as possible for communication. So that's a really important resource to know about. Then we talk about all these self-management things and making sure everybody has a state ID. Everybody who leaves our clinic leaves that day with a wallet-sized card that has their medication list that's been updated, their allergy list that's been updated, their active problem and chronic medical issues updated, all in that one card. And we give printout copies right there in the moment and say, here, it's important for you to start carrying it now. We also talk about medical alert options, whether it's a medical alert bracelet, the old-fashioned metal kind. Dr. LeCompte earlier showed the flash drive, and sometimes people will get a medical alert bracelet that has a flash drive on it, and we recommend against that because if you bring a flash drive to us in the healthcare system, we can't put it in our computers because of viruses. So we're like, don't even waste your money on it. Sometimes an old-fashioned paper copy is actually the best thing. We talk about things with self-management like refilling your own prescriptions, making own appointments, checking yourself into appointments, all those kind of strategies, and we have checklists, which we also have available, which I know is one of the questions. And then everybody leaves that day with an after-visit summary, which has this entire plan written out in it. So it's got the links. Here's the phone number for this new doctor. Here's the information about how to get the records sent to them. Here's the list of things to, here's who to talk to in the state about the education issue you're having. And they leave with all that stuff, which is usually a several-page long document. So because I just ran through this really quickly and we have a short amount of time, we made videos that Jen mentioned earlier. NYMAC funded them, addressing these kind of 4 big domains, one on legal and estate planning, one on options for what to do after high school about vocation, one on where to live in the adult world, talking about independent living, all the way to institutional living and everything in between, and then one on taking responsibility for your own care. So those are the YouTube links. Share them widely. They were all filmed with real live people who have special health care needs in their families, and we're very, very grateful to those people who allowed us to film their lives and their stories. And then just another shameless plug, in the next probably 2 weeks or so, you should be getting notification about 2 more videos that will be published that are actually being funded by the Genetic Alliance Impact Award. One is on planning for a family, which tends to be a taboo topic, but we want people to be educated about what's planning for their future. And then one on becoming an adult with a genetic condition, talking about some protections and as far as employment law and those kinds of things go. So those videos will be available, and you should be getting links to them soon. But the other ones are already on YouTube, and you can share them widely. Also, they're on Got Transition, and Got Transition has a lot of resources on there as well. So I think that's what all my topic is. I want to see. I'm sure there's a million questions that have come in.
Yeah, hi, Corey. Thank you very much. We've got time just for a few questions. One of the questions was about finding adult home care services and DME support, especially if the individual is moving out of the area for college. Do you have any thoughts on that?
Yeah, so that's a really good question. So one of the challenges, I think, in that setting or that issue is about insurance and knowing what insurance will pay for. In the adult world, a lot of times if someone's changing from one pediatric-centered insurance to an adult insurance, let's say maybe switching from the kids Medicaid to adult Medicaid, and depending on waivers in your state or if there are certain funds available for certain types of diagnoses, that may be something to consider. Additionally, there are a lot of disease-specific groups out there that websites that if you Google like DME and, I don't know, spina bifida maybe, and that state, it may link you right to them. But I have resources too that I could send out in that sheet you send out afterwards.
Great, thank you. And time for just one more question. With regards to the study that was done at DuPont prior to getting funding for your center, what questionnaire did you use to demonstrate that adolescents, now young adults, with special health care needs were not satisfied with their transition?
Oh, so we actually created our questionnaire ourselves. The Title V program did, and it was really, I think, a question of like, hey, you came here for all these years. Did we do a good job? Have you found adult doctors? Did you get advice from our doctors? What was it like? All those kinds of questions, and that's where the patient satisfaction comes into play. That study is actually available. I'll send a link to it in the thing that goes out, but it's actually available online through the University of Delaware, and the entire survey is in there as well.
Great. Is your card that you were mentioning also available in your online resources? There's been a question requesting that card.
Well, so we make it for every individual patient in the moment, and so we have it embedded into our electronic medical record. But there are some really good resources out there. Sick Kids in Canada has a really good website where you can actually do I forget what they actually call it, a health history card maybe, and you can choose. Thank you, Health Passport, where you can choose one of, I think, maybe 50 diagnoses now that you can go through this entire list, like if you have spina bifida, and say, yes, I cast, and this is my size, what size cast I use. And it has a whole bunch of things already embedded in that you check off, and then you can print it out right there in the moment. That makes it relevant to you if you don't have, if you're not seeing me in the transition clinic.
Wonderful. Well, thank you so much, and we will certainly get resources and the slides sent out to all of the attendees on Monday after the call today. We do have another webinar scheduled on transition for March 11th at the same time, 1 o'clock Eastern Time. This webinar will be on adolescence to adulthood and assumption of responsibility for self-care for patients with disabilities. So please plan to join us again. Also, a short questionnaire about today's webinar will be sent to all of the attendees. Please just take a moment to fill that out. It's very helpful for us to have some feedback on these webinars so we can provide you with additional resources in the future. Thank you again, and everyone have an excellent day. Thank you.